Welcome to the Speaking Women's Health podcast. I'm your host, Dr. Holly Thacker, and I'm so glad to be back in the Sunflower House. And joining us on this special episode is an endocrinologist, Dr. Ula Abed Alwahab. Welcome, Dr. Abed. How are you doing?
I'm doing great. Thank you, Dr. Thacker. How are you?
Oh, I'm just great. And I love seeing you in clinic in our Center for Specialized Women's Health, your beautiful face on Thursdays. And I want to tell our audience a little bit about you. So you're an internal medicine trained physician who then went on and did fellowship training in endocrinology, metabolism, diabetes. And you are appointed as an endocrinologist, and you also see patients in the Center for Specialized Women's Health in person and also virtually. You went to medical school at Damascus University School of Medicine in Damascus, Syria, and you completed your internal medicine residency at the prestigious Emory University Hospitals and School of Medicine in Atlanta, Georgia. And then you completed your fellowship in endocrinology and metabolism here at the Cleveland Clinic Foundation. And your main interests are in endocrinology and women's health, specifically polycystic ovary syndrome, as well as fertility in young women with PCOS. And you direct our PCOS clinic at the Women's Health Center in the OBGYN Institute, as well as the PCOS program in the Endocrinology Metabolism Institute for the last 7 years. Wow, time has really flown. And you have published in the area of PCOS. You've also done guest authorships for us on our Speaking of Women's Health website, which is speakingofwomenshealth.com. And we have lots of free information for women. And if you haven't caught that column on PCOS with Dr. Abed, I certainly recommend that you do so. But we're going to get into a lot of detail. So tell me, Dr. Abed, what made you interested in PCOS in the first place to focus on this area?
So thank you, first of all, Dr. Thacker, for the great introduction. I don't know if I really deserve that much, but
Yes,
thank
you
you.
do. Yes, you do.
So honestly, from the very beginning, when I was in medical school, I always was interested in women's health, and not necessarily OBGYN as a specialty, but just caring for women's health. I always found there is a missing piece between subspecialties, and then going through internal medicine, you almost do not get exposed to women's health at all. Maybe a
That's
little bit
right.
in primary care in the clinic, but not much. And then through endocrinology, if you go to the history of endocrinology, you see endocrinologists from previous generations, they used to be very heavily involved in women's health and fertility. And then nowadays, during the whole entire fellowship, I can't think of any rotation other than the one I did myself with a fertility clinic that focus on women's health. Although it's all about hormones, and women, they do have a lot of hormonal issues because of their throughout their life they experience a lot of hormonal changes. So, so that's what got me really interested to learn more and try to find the connection between OBGYN, family medicine, internal medicine, and endocrinology. And I would be lying if I said I'm an expert. I am still learning, but I try to investigate more and learn every day about something new about women's health to be able to help women throughout their life in terms of hormones and endocrinology.
Now, tell us exactly what polycystic ovary syndrome or condition is.
Okay. So it's a very common disease, obviously being diagnosed a lot in the last decade for many reasons. Not only because now we diagnose things a lot and people are seeing doctors more, but also because we have more an epidemic of obesity and insulin resistance. The more weight you gain, the more likely you will show symptoms of PCOS. So, what is PCOS? It's a disease that affects many women. and it can be linked to obesity, metabolic syndrome. It does cause period issue, irregular periods, most likely missing periods, and signs or symptoms of high androgen levels or high male hormone levels. So that can manifest as hirsutism or facial hair, acne, hair loss. And many people, talk about weight gain that comes with PCOS, not necessarily caused directly by PCOS, but comes with PCOS, and it does affect fertility pretty much. I mean, probably most common cause of infertility in women at certain age is polycystic ovarian syndrome. Why they called it polycystic ovarian syndrome? Because that's how it looks like under ultrasound.
Lots of little
That
cysts.
Right, right in the ovary. But honestly, that name is not the best name to call it. I would like to call it more of um, maybe a metabolic ovarian problem, if I may name it something. So, but polycystic ovarian syndrome is what's known for, and that's the appearance under ultrasound, but this is what it entails.
No, I think that's really excellent. A lot of times people think, oh, I didn't have a bunch of cysts, so I don't have polycystic ovaries. And the one area that this condition transects with my practice, which mainly focuses on menopause, is that if women have too much androgens, which I think a lot of women don't realize, we actually have more testosterone gram for gram than estrogen. It's just that men have 10 times what we have. But if those balances of the sex hormones get off, it can affect so many other endocrine systems and insulin. And when you have too much testosterone, you can get hair growth or acne or hair thinning. And my all-time number one listened podcast since I've started this season, this year in 2023, although our listeners may be listening to this in our second season in 2024, because we're right on the edge of the new year, was on hair thinning. And certainly it depends on if you're genetically predisposed to get those skin and hair problems. But even if you're not, if you have PCOS, it's a problem for a lot of different reasons. And a lot of younger women figure it out because of abnormal periods and fertility, but it really has such far-reaching consequences, which is why every woman, especially women who have this metabolic problem, need to be aware of it. So what's about the average age that women get diagnosed, or does it take them a long time to get diagnosed?
Yes, yes, I think that's a better way to ask the question, because they do get long time before they get to us and get officially diagnosed, but they do struggle for many years before the diagnosis is made, unfortunately. But I hope going forward, more doctors are aware and able to diagnose PCOS earlier. And to tell you the truth, we used to see PCOS or diagnose it when women were ready to start a family. So they would stop, birth control, and they would start actively trying for pregnancy. And guess what? They either don't get a period or just get a period every few months, and then they get diagnosed and so forth. However, nowadays, because of everything we're living and the environmental changes and the sedentary lifestyle, we are seeing PCOS at younger ages. We are seeing PCOS at 20s, actually at teens, and
Teens.
sometimes, yes, and sometimes even starting with menarche, like some patients are not getting menarche means starting the menstruation. Some patients are not even seeing the period for the very first time that like other girls would experience until really late, only because they have PCOS, nothing else. So it's definitely increasing for due to, as I said, these environmental causes and problems in lifestyle. But also, hopefully, doctors are more aware of it and diagnosing ladies earlier and helping them earlier.
Uh-huh. Uh-huh. Yes. And is there a genetic component? Like, should people be asking if their mother or grandmother or aunts or older sisters had PCOS?
So that's a great question. I get that asked a lot. There is really good studies about genetic component of PCOS, and honestly, it's only 3% of PCOS is genetic or is that's what
Wow.
we know. Most of the time, it's not.
Wow.
Most of
Okay.
the time it's not. And when I see patients in the clinic, I ask them about, family history. I can tell you most of these patients, they don't have PCOS in their mothers or grandmothers, but they do have it at their age, at this generation. So it's only minority of patients that would tell you clearly that their, mothers or, grandmothers or sisters or cousins, they have clear-cut PCOS as we know of it nowadays.
And certainly, I think that even women that aren't interested in fertility should still get evaluated, right? If they're missing periods or they have abnormal hair growth or they've had recurrent ovarian cysts, they have that central weight gain. I'm so interested in the research that you've done with the two different types of PCOS. Can you talk a little bit about that and what some of the dietary and other treatments are for the two different conditions, type 1 and type 2 PCOS?
Yes, yes, absolutely. So first of all, yes, I mean, I do encourage women to seek help and see their doctors if they experience irregular periods, facial hair, abnormal weight gain, all these things that are linked to PCOS early on, not to wait until they are planning to start a family or looking for fertility. In terms of PCOS, I like to call PCOS a spectrum of disorders because this is really how patients are. They really fall into a spectrum. And that spectrum really, if we're going to talk about like the two sides of the spectrum, one side would be the lean PCOS. So these women, you see, they don't have any weight issues, normal BMI, no signs of insulin resistance, but they do still have facial hair and they do still have irregular periods and they are not ovulating and they are having infertility issues. And the other side of the spectrum is the most common phenotype or presentation that we see here in the US, which is higher BMI PCOS. So these women, they do have a weight problem. They have same thing, missing periods, no fertility, but the androgen level might be high or normal, and they might have facial hair or not, but they still have the same exact pattern of PCOS with the other one. So both of them have the period issue and the infertility issue, but they are different in terms of insulin resistance and the androgen levels. And they are treated differently.
Okay, so is one worse than the other? I would think the type 2 is worse because of the insulin resistance and the obesity, but they're both
Yeah,
still a problem.
yeah. So I don't know which one is worse. It really depends on what you're looking for. But yes, of course, if we're talking about long-term consequences, then if you have insulin resistance and pre-diabetes, that gives you a risk for heart disease, for diabetes, obviously, and for many other problems in the future for sure.
Yes. And I know you've done some really innovative research in terms of dietary
Yeah.
treatments and fertility, even having better outcomes than some of the standard, treatments that maybe the average fertility doctor, average GYN, or average endocrinologist might recommend. Tell us about that.
Yeah, sure. So that was really in the beginning of my career that we started a ketogenic diet program for PCOS. And the results were really very interesting. So before I tell you about that study, let me just tell you something about PCOS in really simple words. So PCOS, there is an ovarian problem that we know about. The ovary is sick, is producing extra androgens or male hormone, whether that's caused by blah, 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 but that's a problem. And then there is another problem on top of it that is making the first problem worse, which is insulin. High insulin level does affect the ovary and does make the ovary sicker and producing more androgens, and it's a vicious cycle. So these are the two problems. We might sometimes not be able to really fix the ovary, the first problem, but we can definitely, and we have really good tools nowadays to alternate and hopefully fix the second problem or make it better,
Okay.
which is insulin, which is high insulin or insulin resistance, as we call it. So the study was basically about ketogenic diet in PCOS, and these women, we put them on ketogenic diet, which is a very strict low carb, diet that pushes the body into ketosis because there is no carbohydrates. And we were following them for a few weeks, and we were monitoring their weight, their periods, as well as other parameters. And it was very interesting to see how ovulation was restored in a very short period of time when you take the insulin out of the equation. So
And why
I,
why why do you think that is?
as I said, because high insulin is worsening the ovarian
Function.
function. So once you took that out of the equation, the ovaries start feeling better and functioning better. So it was really interesting, the robust change that we saw with keto diet. Keto diet is just like, cutting out the whole insulin current in the bloodstream completely. Now, I just want to say that it's not necessarily the treatment or the best treatment for PCOS. I still recommend ketogenic diet for a few patients that we can talk about in a little bit, but it's not the only way to treat PCOS, and it's not definitely the permanent or the long-term way to treat it. I just want to, comment on that because many patients ask that question. I just want to make sure that they understand it was a short-term study just to see what would very low carb diet or ketogenic diet, how would it affect PCOS? And yes, it does affect it, and it does make it better.
So if someone is very anxious to hurry up and get pregnant, maybe they might want to do that. And what about going like on a strict carnivore diet? I see a lot in the media about people promoting that, not just for weight loss, but less autoimmune conditions, faster weight loss, better mental clarity. Do you think there are certain people that are just genetically uh, predisposed to just not tolerating any carbs at all?
I wouldn't say that. However, I mean, these strict diet are still, we still recommend them for short period of time for certain goals. So I do see patients in my clinic who are looking to do, for example, IVF in 2 months, and they really want to be in the best shape possible for that IVF process. And that would be a
And
patient
just for our listeners, IVF is in vitro fertilization.
fertilization.
Yes, because we're so used to our medical lingo. And so that's invasive and expensive and time consuming. And people really want it to work because each round is psychologically and physically and is financially a big deal.
Correct. Yes. Thank you. Yeah. So to prepare them for that procedure coming up in 2 to 3 months, if they have, as I said, significant insulin resistance and maybe pre-diabetes or even diabetes, that would be the patient I would put on a, really restricted diet for a short period of time. We follow them monthly. We do labs monthly to make sure everything is okay until we can get them there, and then we can transition them to a Mediterranean low carb diet, which we recommend a lot in PCOS. But yes, so we do still use the strict diet for short period of time for a certain goal, not for everyone and not forever.
And is that the same thing as a protein modified sparing fast, or is that just more of an uber keto diet?
So that's a great question. PSMF, or protein sparing modified fast, that was described and many papers throughout the Cleveland Clinic from endocrinology, actually throughout 90s and the 2000s, were published about PSMF. We reviewed the PSMF protocol, and a few years ago, actually, it has been a while, probably 5 or 6 years ago, we decided to make it a little bit more tolerable, and we changed the name to a keto diet. We do have guidelines of like how much protein, fat, and carb in it, but we did make it a little bit more tolerable. So we did increase the fat a little bit so people can do it more comfortably without necessarily causing any problem. And I actually have another paper, speaking of, about the keto diet and lipid profile, and how the keto diet did not increase or worsen lipid profile in 6 and in 12 months in patients. So
Oh, that's
yes,
very interesting because so many people say, "Oh, I don't want to eat a lot of meat or protein or fat because it's going to affect my cholesterol." But maybe in those people, that's not the case then, right?
if it's medically monitored, as I said, and if they follow what we wrote for this diet, then yes. If you just follow a keto diet from the internet, you might not be necessarily eating super healthy, and yes, your cholesterol might get worse, and I have seen that. But if we, follow the guidelines for these diets that were very well written by experts and well studied, then yes, your lipid profile or cholesterol is not going to get worse.
Excellent, excellent. And getting back to in terms of how, because I know we have several physicians who also listen to this podcast too, and it's good for women who are going to see a physician, understanding maybe some of the diagnostic tests that are going to be ordered. How do you specifically diagnose PCOS? Do you have a PCOS panel? Are there certain labs that are more helpful than others?
Yeah, so first of all, PCOS is a clinical diagnosis, and that doesn't mean we don't do labs. I do actually a bunch of labs, and I do have a PCOS panel, but I do the labs mainly to make sure there is nothing else hormonally. So I'm not dealing with like a tumor producing testosterone or, like a congenital adrenal hyperplasia or something else. All these diseases are, similar and they present similarly to PCOS, but they are not PCOS. So I do the labs for a lot of reasons to rule out something else, make sure there is no other issues. But basically, it's a clinical diagnosis. So if you have irregular periods, especially missing periods, and you do have facial hair, acne, hair loss, then most likely you do have PCOS. I yeah, if I do the labs and I see high testosterone level as well and signs of insulin resistance and all that, then that basically makes the diagnosis more likely, but it doesn't necessarily just make it with a blood test.
And so tell me just some of those blood tests that are in the panel. That you get an FSH, LH,
Yeah.
DHEAS, testosterone levels.
Yes. So we do the estrogens, the androgens, 17-hydroxyprogesterone for congenital adrenal hyperplasia, prolactin for sure,
Prolactin.
thyroid level, and then sugar test, A1C, fasting glucose, lipid panel really helps to see what the triglycerides are and the LDL. There is one more that I am very passionate about and very interested in researching more is anti-Mullerian hormone, which I check in every patient I see with PCOS. And it has
Ah,
been reported that, yeah, that the higher the AMH, the more severe the PCOS and more resistant to ovulation induction.
hmm.
And I'm hoping honestly to study it further and see if what we're doing in the clinic is reducing or decreasing or helping the anti-Mullerian level. Because if you do, then most likely you're helping that woman get the PCOS under control and maybe better chances for fertility. So that's one lab that I make sure I check in PCOS commonly. So.
And do you do pelvic ultrasounds or refer to gynecology? Because some of these women certainly can be at risk for endometrial hyperplasia, uterine cancer, etc.
Yeah, so I don't order ultrasound in every PCOS woman. However, as you said, if someone comes to the clinic and they say, I haven't had a period in 2 years, that's alarming. That's very alarming. And yes, they do need an ultrasound to make sure they are not having an endometrial thickness or hyperplasia. And the other one that I would order an ultrasound if I am suspicious of something else and it's not only PCOS. So I don't necessarily order it to look for these small little follicles that are stuck in the ovary and caused
Sure.
by the problem, but I do order it for other indications if I'm thinking of something else.
Yes. So you've been listening to the Speaking of Women's Health podcast. I'm your host, Dr. Holly Thacker, and we are still in the nice, warm, sunny Sunflower House with endocrinologist and PCOS expert, Dr. Abed, who is in our Center for Specialized Women's Health every Thursday. And she's really done some pioneer research. She's interested in women's fertility, women's metabolic status, risk for diabetes, long-term health outcomes. And before we start talking about some of the other therapies, we've touched, of course, on the importance and the innovations of dietary therapies. What are some of the other lifestyle things that you recommend? Do you do intermittent fasting? Should women go out and get buckwheat farinata as their flour, or should we tell them to take berberine, which some people are touting as the oral Wegovy, which of course it's not, but that's out there on Instagram and all that other stuff.
Yeah. So actually, when we enroll women with PCOS in the PCOS program, they do see the endocrine dietitian first, and those dietitians, they do have extra training in endocrinology, and they do have knowledge about the PCOS program. So they go over what the patient is eating and making sure everything is PCOS friendly, let's call it that way. And they do give them the PCOS book. We have a full book to explain how to eat for your PCOS. That's the first one. And then we do give them a free exercise consultation with our exercise physiologist. So those exercise physiologists also have knowledge about PCOS, and they help women exercise not excessively and not too little so that can help their PCOS. We do have also a psychologist because many PCOS women, they do have issues in terms of relationship to food, emotional eating, stress eating. So we do have counseling for that as well. In terms of supplements, it's complicated. Well, the problem is we doctors like evidence-based, and unfortunately, not everything can be evidence-based.
Right.
So I'm not against all supplements, but I'm gonna say it's not only supplements. So you're welcome to try to supplement. The one that got a lot popular is mayo-inositol for PCOS, and I hope one day we'll have a large trial to say if it really helps in PCOS. I mean, I see a lot of
And
PCOS patients.
say that supplement again, myo-inositol,
Yeah, myo-inositol. Yep.
myo-inositol.
Mhm.
And what is that chemically? I presume that's something over the counter that people can purchase.
Yes, so it's over the counter, and what it does is, at least that's what we know, it does decrease the insulin level. It does decrease insulin in the on the ovarian level, so it might help with ovulation. If the, I mean, is it true? Is it not true? We really need a large trial to tell us. But that's the one that I would say it's safe. So if you want to mention a supplement, that would be the one I would mention. The other ones, I don't know. I mean, again, I'm not closing the door completely, but I'm gonna say it's not gonna be magical. It's okay to use supplements if you are interested and see how you feel on them, but it's not the only answer.
Hmm. Now, women who have PCOS and who want fertility and then get pregnant, do they have higher miscarriage rates? Do they have a higher rate of gestational diabetes than the average woman? Is there anything they need to be aware of during their pregnancy?
Yeah, so because PCOS comes almost hand in hand with obesity and insulin resistance, then we do know that, obesity does cause pregnancy issues, can cause complications during pregnancy, including gestational diabetes and the higher rate of miscarriages. So it's not necessarily just the PCOS itself, but what comes with it. So insulin resistance metabolic syndrome does cause more pregnancy problems.
Now, certainly, obviously, having a highly processed diet, things that taste really good, that are loaded with sugar, which is, so addictive and obviously drives insulin levels, simple carbohydrates. Um, what about the seed oils? I mean, so I think people know to avoid simple carbs and breads and especially sugars and a lot of pre-processed foods. But what about seed oils? Do you think they play any role at all in PCOS?
I mean, again, that needs to be studied, and it's not an easy thing to study diet because it's really hard to report and really hard to follow people and see what they are consuming. But
Mm-hmm.
what I would like to advise in general, not only in PCOS or diabetes, but in general, try to eat whole grain, try to eat whole foods, lean meats, olive oil, healthy fats, for all the problems, and try to exercise regularly. You don't have to go necessarily to the gym 5 days a week and spend an hour there. You can just walk and jog and do some muscle strength exercise at home, and that would be enough for your body. But keeping healthy lifestyle, trying to eat, natural nutrients, that would help a lot, and that will go a long way. And unfortunately, as you said, processed food is so available and so ready for all of us who are super busy and and have a lot of responsibilities that we tend to, depend on them for most of the time. So I know it's not easy to eat good food, but just do your part, do your best to stay healthy.
Yeah, one of the other most popular podcasts after hair thinning that I've done is on superfoods, trying to get the
Hmm.
most out
Hmm.
of your foods and certainly whole foods. It seems like the food pyramid that the United States government promoted, taking away fats, heart healthy fats, and demonizing eggs and meats, and then putting all these simple carbs, you know,
Yeah.
telling people 8 to 10 servings a day. It seems like that might be fine for some people, but a lot of people that are predisposed to insulin resistance, it seems like it's the wrong type of food.
I agree. Let me just make a small comment. I agree 100% on that. Like now things are a little bit changing. So we do have few data describing how cardiac risk and cardiac disease is not necessarily linked to fat diet, but mostly high carb diet. So maybe now we're starting to realize that all these recommendations are not necessarily true. And from the intermittent fasting data, we learned that well, maybe we shouldn't eat 6 to 8 times a day. Maybe that's exhausting for the pancreas. Maybe we should give that pancreas a break and lower insulin level to almost zero between meals for at least 4 or 5 hours. So yes, things are changing and we're learning more about, how to eat well and healthy rather than just, a fixed recommendation that everybody should follow.
Hmm. I mean, I try to recommend intermittent fasting for most all of my adult patients, uh, just for anti-aging effects, at least which you can study in animals pretty easily, and the dropping of the insulin and just resting the digestive system and pancreas and liver because eventually everything wears out. And if you live long enough, potentially, anyone could get diabetes. So you really have to take good care of your pancreas. I think limiting alcohol is also very important in childbearing women or just in anyone who wants to reduce cancer risk and help protect their pancreas. Now, I have read some data where when you intermittently fast after, like you're getting into 16 plus 17, 18 hours, that your human growth hormone increases and testosterone increases. So would that be bad for somebody who's already got too much testosterone from insulin resistance, or would it be good for them because it's dropping their insulin and then that's helping their ovarian dysfunction and the elevated testosterone?
I mean, that would be a great protocol for a study. What I can tell you from intermittent fasting data, we do know that fasting for 12 to 15 hours is very healthy, is tremendously healthy. Now, I can't tell for like fasting beyond that because there is obviously less data about, the 20-hour fasting. There is more data about 16 to 18-hour fasting. So I would say, 12 to 16 hour is definitely beneficial, is definitely good for your pancreas, for your PCOS, for your overall health, for your weight, obesity. So I can tell you, yes, I do not expect stress hormones, including growth hormone or cortisol, to go high at that point because obviously, I mean, if you go to physiology, you are still burning the glycogen stores in your liver in these 12 to 15 hours. You didn't get to ketosis, stress hormones yet. So that is still a good period of fasting to get healthy. Beyond that, beyond 12 to 15 hours, I don't know. I need a study to back me off. But yeah.
Yeah, I try to aim for at least 16 hours. And a lot of people think that means they're just not sitting down for a meal. No, it means your coffee's only black. Okay, not just a little bit of almond milk, not just a little dab of butter, not
Yeah.
artificial sweeteners, not gum, not even supplements that have calories in them. A lot of women with osteoarthritis take glucosamine, which has some carbohydrates and sugars in it. So people really have to read labels and pay attention, but everything you put in your body really does affect it. Do you foresee these exciting new obesity medications, the GLP and the injectables and now some oral medicines are on the horizon? Do you think those will be very helpful in PCOS, or do you think people just still have to only get back to the diet and the lifestyle and the weight loss to really help the ovaries as opposed to just going for something simple and easy and also expensive?
Yeah. So, I mean, we do know now that diet and exercise alone are not enough for obesity, let alone PCOS, for obesity in most cases. And we do know that we do need these medications, and these medications work very well. So, in terms of PCOS, actually, these medications, that GLP-1 agonists like semaglutide or others, they do decrease insulin level quite a bit between meals. Let me mention that because some people will ask. So it does decrease insulin resistance quite a bit, more than any other medication that we knew about before. And that by itself, as we talked about, does help the ovary tremendously. So I do have quite a bit of patients with PCOS. They do get better. They get regular periods again spontaneously just by using these medications. They feel healthier, things are back to normal, less facial hair using these medications. Now, are these medications enough? I would say not, because at some point, you have to think about weaning down and then eventually off. So you do need to keep your metabolism going with good lifestyle, with diet, exercise, good sleep, less stress. Yes, these medications are great in addition to lifestyle changes.
Yes. So I do think reducing stress and getting sleep, which decreases cortisol, is so important. We have several podcasts on sleep and other podcasts on being less sweet and reducing insulin resistance. What are your thoughts about glucophage metformin? My PhD son in molecular medicine and cancer genetics, who I'll be interviewing on a future podcast in that field, when he was studying metformin, he's like, this is anti-aging. I want to go on it. And I'm like, you don't have any insulin resistance. Your metabolic profile is great. Your muscles are ripped. You don't need metformin. But just from a cellular and molecular level, he was very fascinated with metformin, which made quite an impression on me.
Yes, yes, thank you. Thank you for the question. So, yeah, so, we endocrinologists used to think that metformin is gonna do magic in PCOS back in the 80s, but unfortunately, unfortunately, that's not true nowadays anymore. So actually, the largest trial that was done on metformin in PCOS and did show that 50%, which is a huge number of PCOS patients, do get better with metformin alone. Get better means regular periods and ovulation again. It was done in the 80s and published and got metformin into the PCOS world. If you review the data, the patients on that study, all of them or most of them had normal BMI, and the highest BMI was about 25 to 26.
So not that
So
high. That's
not
pretty
that
close to
high.
normal. Not that high.
Exactly.
Uh-huh.
Exactly. So, and that study was never replicated later. So the glory about metformin is not there anymore. And I try my best to be very selective of who to give metformin to, because I hate to give it to someone and 2 months later they're like, you gave me this medication, all these promises, and nothing happened. I didn't lose weight, periods are still gone, and facial hair is still the same, and no fertility. So what I would like to
That's
say
one
is,
unhappy woman. One unhappy woman.
yeah, yes, yes. So what I would like to say is, yes, metformin works, but we have to be selective. It does work in patients who have lower BMI, so maybe that would be honestly a very interesting research project to see at which BMI metformin stops working in PCOS. But I can tell you from experience at lower BMI, so we're talking about below 30 for sure, and maybe below 28 even. That's when you see metformin working very well in PCOS. But beyond that, and that's the majority of our patients, it really doesn't do anything. On the
Hmm.
molecular level, it works great, but when you have significant amount of insulin resistance, significant amount of fat percentage in the body, it's really hard to overcome that with metformin alone.
Alone. So I've seen it work very well in some women who are just a little bit overweight and a little pre-diabetic, and they're trying to lose weight and exercise and intermittently fast and follow, more of a protein, fat, low carb type diet. boosting their vitamin D, which I always recommend because there's vitamin D receptors in the pancreas. And there's some evidence showing if you boost vitamin D, you can reduce diabetes. People with strong family histories of diabetes. So I think it's something to talk about, but you don't want the horse out of the barn. And unfortunately, that's the case with so many of our patients. And the work you do is just so fabulous. We really appreciate it. So women that have PCOS and fertility concerns, younger women that really want to see a PCOS expert like you could go on our website, speakingofwomenshealth.com, or our Center for Specialized Women's Health. Give us a call at 216-444 for her. That's 216-4437. It's not a 1-800 line. When I opened the center over 20 years ago, I wanted it 1-800, but it was a sex line that was already taken. So it's 216. We're in Northeast Ohio, 444 for her. And so that's how people can reach you. Is that right, Dr. Abed? And
Yes, yes.
I just wanted to touch a little bit on your personal life. You're a mom of 2 children, beautiful children. I've seen some of the wonderful photographs you've taken of them. How old are they and what are their names?
So Saeed is 5 years old now. He just started kindergarten and
Oh,
he's happy. And my daughter Selwa, she's 2 now. And yes, the best stage ever. She's happy and bubbly all the time.
oh, that is so delicious, so gorgeous. I have a 3-year-old granddaughter and a soon-to-be 1-year-old grandson and a little almost 6-month-old baby. I just love those ages. And 5, I think, is the most glorious age. They just adore you and they're just so cute. And you have so many interests and talents as well. I wanted to let our listeners know that you're certified by the New York Institute of Photography, and you're quite expert in portrait and landscape photography. And hopefully our listeners, if you go on our speakingofwomenshealth.com site and our social media, we hope in the future to be featuring some of Dr. Abed's photography. She's going to be working with Lee Kleckar, who is our wonderful executive producer of our podcast. And sometimes she's a guest podcaster. So any other parting words you have to say about being a mom, photography, being an endocrinologist in women's health?
Well, it's all about balance, Dr. Thacker. I can't imagine my life being a doctor and a mom without my other life of as a photographer or an artist. So it's been like that since high school, honestly. So I really can't do this without this, and I can't do this without this. It's always about balance, this and that. So I do feel that art recharges the battery for the following day in medicine, and then vice versa.
That's excellent. So it sounds like you're using both sides of the brain, the left side of your brain, the analytical part, as well as the right side, the creative part. And doing that is, we recommend that for good brain health. And certainly if you've got good metabolic health, that's going to help your brain not age as fast, because I know that's one thing women are so concerned about, aging. Well, I would love to have you back again in the future in the Sunflower House. I'd like to interview you on other endocrinologic things, follow up on some of your research, thyroid. I'm going to do a podcast on general thyroid disorders because they're so common in women, but I definitely want to pick your brain, and I'm really looking forward to seeing your excellent photography on our site. I think that will be very engaging for our listeners. So thank you so much. Any other final parting words, doctor?
Well, first of all, thank you so much, Dr. Thacker. That was really lovely meeting, and I hope we continue to collaborate and not only, as I said, in the clinic, but also helping with the website for sure. And but just the last word for every woman, your health matters, and we are here to help you. So don't hesitate to contact us.
So you are living that motto to be strong and be healthy and be in charge. Thanks to our listeners for joining us. If you enjoyed this episode and you want to help support our podcast, please share it with others, donate to our nonprofit, or leave a 5-star rating to review. And to catch all the latest from me, you can subscribe for free. Just hit the follow button on Apple Podcasts, Spotify, TuneIn, or wherever you listen to podcasts. Thanks again, and I'll see you back again in the sunflower house.